Morning, everyone. We are going to call this month's board. Hold on. Call this month's Board of Health meeting to order. For the record, there's a copy of the Open Meetings Act here on the north wall of the legislative chambers, and I do have the official record of notice. So with that, roll call.
Wade.
Here.
Festerson.
Here.
McNally.
Here.
Rogers.
Here.
Jones. Wilkin. Espinoza.
Item 2 is approval of the minutes from the November 15th meeting. Is there a motion to approve? Motion by Wade, is there a second? Second by McNally. Roll call.
Wilkin.
Yes.
Wade.
Yes.
Rogers.
Yes.
Jones. McNally.
Yes.
Espinoza. Festerson.
Yes.
Item 3 is public comment. It's an opportunity for anyone to comment on items Board of Health related, but they are not listed on the agenda. Are there any public comment at this time? Seeing none here and in the Zoom, we'll move on to item 4, which is approval and ratification of the agenda items A through N. Is there a motion to approve and ratify items A through N? Motion by Wade, is there a second? Somewhere. Second by Dr. Wilkin. Roll call.
Festerson.
Yes.
McNally. Rogers.
Yes.
Wilkin. Jones. Espinoza. Wade.
Item V, Director's Report, and sitting in is Justin Frederick. Dr. Hughes is feeling sick, so she is at home. Justin.
Hey, good morning, board. Just a couple things to cover, and then we have a little celebration. But as far as the building goes, we continue to make improvements. I'm happy to report that we have close to 30 cameras now throughout the building and outside perimeter. So I know a lot of the management team and the staff are very happy about that. I think it offers a whole nother level of security. So that's great news. We have started moving into the new space. I think you guys remember hearing Dr. Hughes talking about some of the space that we took from general assistance, or that they kindly gave us, I should say. And we've been able to prep those offices and furnish them with furniture, and staff have began moving into that area. As far as personnel changes, we're in the process of hiring 3 new disease investigators. One of them will be for the STI control program with the increase in syphilis. And then 2 will be in the communicable disease epidemiology section. Within the next week or so, we should be interviewing for the supervisor of communications, which I'll talk a little bit more about during my presentation about the TB response, but I think this is a critical position for the department, especially in the wake of the 2 responses that we had this fall. We're still in the process of looking for a female nurse, so if you know anybody that would be qualified or interested, shoot them over to the Douglas County employment page. We just hired 2 new health educators in the Division of Health Equity. One was to replace a promotion, and the other I think is just an addition, but Jamin can answer to that better than I. We do have our accreditation specialist and workforce development person that both started in the last month, I believe. And the accreditation coordinator just had a relaunch meeting with all of our accreditation teams, so we're looking forward to getting that done. In the next couple months, we'll be starting the budget process for the next fiscal year, so just keep that in mind as we move forward. I did want to give you a couple updates about COVID, RSV, and influenza. COVID, as you know, we continue to monitor closely. We still have our dashboard up, so if you want to look at current numbers, cases, hospitalizations, etc. But we have seen a mild uptick in both cases and hospitalizations. I think good news there is we're not seeing a lot of patients on ventilators or needing acute care. There is a new variant, JN.1, that we're watching very closely. It's kind of becoming the predominant variant on the East Coast. We still haven't detected it here in Nebraska. But I think the key takeaway the takeaway with COVID-19 is that about only 9% of Douglas County residents are up to date on their vaccine. So RSV is still very high. We're seeing a lot of RSV right now. We had over 200 cases reported just last week and about a 20% positivity rate. Some big changes with RSV this year. There's a new vaccine for expecting mothers that are between 32 and 36 weeks, and also for individuals that are 60 years of age and older. There is also a new monoclonal vaccine for infants. It's called Beyfortus. It was supposed to be more readily available and help with equity. However, the manufacturer, I don't think, quite expected such a demand. And so there's a little bit of shortage of the Beyfortus right now. And I've been chatting with the state of Nebraska about how we might be able to assist with some recommendations regarding distribution. Flu activity remains minimal, but is slowly increasing. I fully expect to see that trend continue over the next few weeks to months. We had 48 cases reported during the week ending of 12/2, and we had 98 cases, or nearly 100, reported last week. Again, I think the big takeaway there is if you haven't been vaccinated for influenza, it's not too late. Last week, I met with the 13 biocontainment units across the country in the Center for Disease Control. We're closely monitoring a situation that's occurring right now in the Democratic Republic of the Congo with Mpox. There's a new variant, if you will, Clade 1. It looks to be more virulent, and there are almost 13,000 cases reported, and I believe there were over 500 deaths associated with this particular infection. So we are setting a meeting within our organization to bring all of the department SMEs together and review our response plans. And that's kind of my update. But before I move on, we are celebrating today. Russ Hayden is celebrating his 20 years of service with the health department. So Russ, if you want to come up, I think he wants to say a few words, but Dr. Hughes did say, and she wanted me to let everyone know that she's very grateful for Russ and his willingness to constantly be teaching her about environmental health and air. She says she's learned so much about sanitation, air quality, and how hard his entire team works. So congratulations, Russ.
Thanks, Justin.
And I'll let you say a few words and we can take a picture. And then if you have any questions for me.
Well, it's been 20 years. I don't know if I remember what I was supposed to say. No, just kidding. It's been a great 20 years. You know, the health department is an excellent place to work. You know, I've had great mentors over the years that have come and tried to help me out throughout my career, lead me in a lot of ways. And that's what I appreciate about the experts at the health department, is that they're willing to, you know, train the individuals that are there, give them insight on how to be a good leader. It's just stuff like that. Even the current employees are great at mentoring me, you know, on what I need to do and how to go forward and to be a good leader. So it's been an excellent 20 years. I can't believe it's been 20 years already. You know, we just went through Dr. Poor as the health director. She was a great director. Dr. Hughes is even, you know, a fantastic director. I can't wait for the opportunity of another 10 or 20 years. And I look forward to all the advancements that are taking place at the health department and being an integral part to, you know, advance the environmental section even above where it's at today. So I appreciate being recognized for 20 years of the health department. Thank you.
Russ, for you, I don't know, I'll yield to Marty first. She was probably the only one on the board at the time when you came, so I don't know if she didn't have anything. I'll just personally say thank you for the service, particularly for that department. It's a department that doesn't get high visibility, but the need is very great, and I'm assuming your visibility will jump up in the next couple of years as this climate discussion and city's climate plan comes into play. So we look forward to seeing a lot more of you up here for
Right.
discussion.
Well, environmental health is the hidden profession. A lot of people don't recognize the amount of work we do to keep people healthy. And so a lot of the staff doesn't get recognized for that either, between swimming pools, septics, wells, air quality. It's really kind of hidden back there that we are protecting public health. That doesn't mean it always has to be hidden. So we're working on, getting a lot of that information out there for the public so they can see exactly what the health department is doing to, help save a life. And I tell that to the employees all the time is you never know, who you affected today, who you made happier, and what life you might have protected. And that's what the staff really works for.
No
So
doubt.
thank you.
All righty. Thank you again.
Russ?
Yeah.
I'm serious about the next 20 years.
I hope so if I'm still alive.
It's been a real pleasure, and I don't see Russ that often, but in hindsight, that's probably a good thing. In the sense of you're out there busy protecting the public, and I appreciate your service so much.
Right. The only time you see me is when there's some bad news out there. So
Yeah.
that's kind of unfortunate,
Yeah.
So maybe we can celebrate the good stuff.
We can.
Thanks.
All right, thanks.
Thanks again. So Justin, I do got a couple of things. You all need, have y'all took it? Yeah. It looks awkward. We might want to come around because it's gonna look.
Come on in. Come in. 20 years doesn't come very often.
Every couple decades.
Actually got everybody in.
Thanks, Lord. Appreciate it. So Justin, I'm just, the two questions. One, I'm just curious, have you all, are the flu numbers at pre-COVID levels? Because I know for a minute it's kind of down, people were wearing masks and it wasn't there. Are you seeing that flu has kind of come back to a level that it was pre-COVID?
It's really hard to say because
Okay.
flu is so unpredictable, but last year we had kind of what we were calling a tridemic where we had increasing COVID, influenza, and RSV.
Mm-hmm.
I'm optimistic that we won't have a bad flu season, but it's still too early to predict. We could see influenza clear up into March.
Okay.
So, yeah.
So in that in the epidemiology report, you got any concerns about, or is it just like the percentages seem high, but you got any concerns like the November COVID numbers, cases, hospitalizations, anything, or just the percentages seem high just because the numbers are at another level?
Well, the percent change seemed high at certain times, but remember our denominator is still really small. So if we have an influx of cases, that's going to make a big difference in our percent change, right? So I would say that currently, knock on wood, as we move into the holidays, that COVID numbers remain fairly low to stable. But again, stressing the fact that only 9% of our population is up to date on their COVID vaccine or vaccination. So I'd urge and encourage folks to go to get that booster, especially as we move into the holidays when we're around our loved ones and those that are susceptible to poor outcomes if they have COVID infection.
Okay. Thanks. Any other?
Just one question actually about the vaccine. Do you know if that current dose includes the variant, that the GND1 that you were referring to?
The new one, no, it does
the
not.
new-
But no,
okay,
but there is the thought is that it would still offer protection, and also that the current tests available would detect it. But like I said, we haven't yet detected it here in Nebraska.
Justin, where does Nebraska rank in terms of this United States in terms of COVID rates?
Ooh, that's a good question, and I'm not sure. I would have to
I
look
heard
into
that
that.
Iowa, Nebraska, Missouri, and Kansas are the 4 states that have the highest COVID rates in the country.
That could be, and again, I'd have to look. But I mean, looking locally, I would say that our numbers are still fairly low. We start to get nervous when we see our hospitalizations and things start to creep up into the 85 to 90%, bed capacity. We're not there yet, and our numbers actually came down the last week or so. So they're kind of all over the place, but they're not spiking, if you will. But that could be. We could still have very high rates. Again, our immunization rate or up-to-date rate is fairly poor.
And that was a second question in terms of, you mentioned 9% in terms of immunization rate. How does that compare nationwide?
I think nationally it's pretty poor. There's just not been a big interest or uptick in being boosted for COVID. We just a few weeks ago did kind of a big media campaign. We sent out a press release, and I think I did interviews on every major station. I think the newspaper covered it as well. So we're trying to get that information out. We continue to offer COVID vaccine clinics and flu clinics. Again, there was a change with the vaccine though, so we can only vaccinate those that are either underinsured or not insured. Otherwise, public health would have to refer those folks to their primary care doctor or pharmacy. We did, just one other comment, we did receive nearly 70,000 COVID tests. So we are handing those out again in the community. So where we're doing outreach, the libraries, and we have tests in the entrance of our building as well.
Thank you. Good morning. Just 2 questions. Can you share with us and the public what vaccinations you guys have available at the health department for COVID and for RSV?
So for RSV, I don't believe we have any vaccine. That I would have to refer folks to, again, their pharmacy or their doctor. The vaccine, I think, is slow to arrive as well. So even though there's new CDC recommendations for those that are 60 years of age and older, and then women who are pregnant between 32 and 36 weeks, I think it's still kind of difficult to find. But I would highly encourage folks to do their best to shop around to try to find it. And then the Beyfortus is mostly with pediatricians in the hospitals, so that's not an area the health department's involved in. But we still have all of our vaccines for children that we offer through the health department, so all of those kind of regularly scheduled vaccines are vaccine preventables. And then we do have COVID and influenza, but again, that's primarily for those that are underserved.
One more question. With the drop in the COVID vaccination rates, are you seeing a drop in flu vaccination rates?
So we don't track flu vaccine quite like we do COVID, so we'll have to wait a little bit until CDC reports out kind of the uptake or the how many individuals were vaccinated.
Because I think it climbed during COVID when the first vaccine
Yeah, I think
came
everybody
out.
was, the vaccine overall, I think, kind of increased, although childhood immunizations decreased, and so, we're continuing to play catch up with those. Yeah.
Thank you.
Hey, Justin, one last piece. I'm curious, are you all aware of how the vaccination is being distributed, like within the county? Because, for instance, it was a Walgreens that had it. Then I went to a doctor. They didn't have it. Do you all get updated on how that distribution is similar to when it came through? Okay.
I don't believe so, but if Leah or Molly are on, and if you have anything to add, but I don't think that we have a role to play in the distribution of that vaccine anymore.
Okay.
Yeah.
Okay.
Hey,
More COVID. More COVID.
Yeah, go ahead.
hey, so yeah, we don't oversee who gets vaccine to the different areas, like through the different pharmacies and whatnot now, since it is distributed through the actual vaccine manufacturer.
Okay. Okay. Wow. All righty. I think that's it.
Okay, thank you.
With that, item B is building safety organization updates. Did you do that already in your report?
did that.
Okay.
I've talked about the cameras we installed in
Got it.
the new space, yes.
Okay. In presentations, item A, food safety and compliance.
Is this yours? Yeah. Or did they open it? Did you open the presentation? Yeah, just this one. Okay. Do we need to share the screen?
It's the green. There we go.
Thank you.
Increase that.
I'll let you do it.
Okay.
You might want to minimize that, yeah, that one. There you go. Yep.
And then start it. I can't find it. Where is it? Ah, there it is. Okay. There you go.
Good morning, Board.
Good morning.
My name is Adam Carlson. I'm Supervisor of Food Safety and Compliance Section at the Douglas County Health Department. I've been asked to do a program update for you this morning. Yesterday when I was running through this presentation, I was just using the slides to kind of guide my presentation, and it wound up being 40 minutes. So I've been asked to do much less time than that, so I've written a script to keep me on track, but I apologize, most of the time I'll just be looking down and reading. I think everybody's going to thank me in the end. They don't have to listen to me ramble for 40 minutes. So most people are aware that we perform food safety inspections on brick and mortar facilities such as restaurants and bars, but we also perform inspections on a variety of other food establishments such as schools, grocery stores, convenience stores, mobile food units, push carts, temporary event food vendors, farmers markets, caterers, daycares, and summer feeding programs. Essentially, unless it is a food manufacturer, warehouse, or food services for patients in a medical facility, Douglas County Food Safety and Compliance regulates it. Once those inspections are done, the brick and mortar establishments and food mobile inspection ratings are available at www.douglascountyfoodinspections.com. This link is also available through the website at douglascountyhealth.com. Other than the previous routine inspections mentioned, we perform a variety of other actions such as complaint response, plan review, which is where we review the approved blueprints for new and remodeled food establishments, certificate of occupancy inspections for the City of Omaha, liquor referral inspections for the Nebraska Liquor Control Commission. We assist in teaching food safety education class called Serve Safe at the Douglas Sarpy County Extension Office. And we respond to fires, power outages, floods, and sewage backups. We got a couple pictures here. You'll see this one of the fire. This is at the Drover a few years back. It was pretty extensive fire damage, and we come in and give guidance on food safety. The picture on the right, this was recently, there was a strip mall here in Douglas County that had 2 food establishments and a daycare in it. Their drains were backing up, and when they opened up that floor, they pretty much found it was floating on raw sewage. So we came in and gave guidance on the safety of that. We derive our enforcement capabilities from a memorandum of understanding with the Nebraska Department of Agriculture. And during our inspections, we enforced a 2017 Nebraska Food Code, which is largely adopted from the 2017 FDA Food Code with a few exceptions. We have a total of 13 employees in the food safety and compliance section. We have a supervisor, 10 inspectors, which include 2 environmental health specialist 2s and 8 environmental health specialist 1s. We have 1 grant-funded EHS1 with an emphasis in food safety education and health equity. This position is required to be bilingual in Spanish, and we also have 1 secretary. So let's meet our team. Starting with the top left here, we have Teresa Burke. We have an EHS2, Sarah Pastillo, Austin Klingenberg, our other EHS2, Dan Ludwig, Colton Walensky, and myself. Then in the front row, we have Jason Reed, Rodrigo Sanchez, Aaron Jacober, Tamara Rivera, and Robert Pratt. Not pictured in that group photo is Inspector Jeremy Anderson and Secretary Lauren Seeger. So how many people does our program serve? Counting the approximately 600,000 residents of Douglas County and the estimated 12.7 million visitors that our county gets per year, we help ensure the food supply is safe for 13.3 million people annually. So how many inspections does it take to protect a food supply of that magnitude? Well, let's start with the 2,713 brick and mortar food establishments in Douglas County, which receive approximately 3,800 inspections per year. These establishments are given an inspection frequency depending on their risk. Now, risk has nothing to do with the good or bad, how good or bad the establishment does on the inspections. Risk is referring to the types of food practices that the establishment is performing. A high-risk establishment performs activities such as cooking raw animal foods and cooling and reheating temperature control for safety foods. This is typically your full-service restaurants, which are inspected every 6 months. A medium-risk establishment is handling exposed and temperature control for safety foods, but generally don't perform the practices of a high-risk establishment. And if they do, they have implemented standard operating procedures and verification procedures to ensure food safety. These establishments are inspected every 12 months and are typically your fast food restaurants. A low-risk establishment is something like a bar that doesn't serve food, or a convenience store that has only prepackaged items, and these are inspected every 18 months. We have 243 mobile food units in Douglas County. Each mobile unit gets inspected at the beginning of each year before they are granted a permit, and then they get an unannounced inspection during operation at some point during the year. This makes for approximately 486 mobile unit inspections per year. This year, Douglas County had 65 temporary food events with a total of 455 food vendors at those events. Each food booth must pass an inspection before being allowed to operate. Douglas County typically has 5 reoccurring farmers markets, and this year there was a total of 98 food vendors at those markets. Each farmers market food vendor gets inspected once per month from May through October, totaling for 588 inspections. There are 232 child care centers in Douglas County that get inspected once every other year for approximately 116 child care inspections per year. And lastly, we inspected 78 summer feeding programs this year. So that means in a typical year, the food safety and compliance section is performing 5,523 inspections. I should mention that does not include non-routine activities such as 168 follow-up inspections. Follow-up inspections are necessary when a food establishment does poorly on a routine inspection. We did 271 complaints, 185 liquor referral inspections, and approximately 750 certificate of occupancy inspections. Although we don't have to go out on every one of those certificate of occupancy inspections, we do have to review each one to see if the establishment is doing any food operations. So before we review what happened in 2023, I do want to touch on what happened in 2022 that explains a little bit why 2023 looks the way it does. In 2022, the supervisor position was vacant from February through December, and 6 employees left the section. We had a secretary from a temporary staffing agency all year, and an interim supervisor was assigned in May of 2022. We did hire 2 EHS1s in September, and I was hired on as a supervisor in December. All that led to a scary beginning of 2023. In January of 2023, 1,205 establishments were behind on their routine inspections. That was 42% of all food establishments within Douglas County. We had 4 vacant positions, 3 EHS1s, and a secretary. In May, we were able to hire all 3 of those vacant EHS1 positions, and we successfully hired a permanent secretary in June. We were able to hire a grant-funded EHS1 in September. At the beginning of November, the section was declared as caught up on routine inspections, which I determined as caught up to mean less than 1% behind on routine inspections. That 1% does include establishments that have been permitted but not yet opened, or establishments that were closed for remodel, essentially establishments that can't be inspected for one reason or the other. I want to kind of go over some of the complaints that we received in 2023. Complaints typically fall into one of 2 categories. First, you have food and nuisance complaints. These are complaints filed by a person that have concerns about something they saw in a food establishment. They file them in a variety of ways, including by phone, email, or in person. These complaints are then logged into our internal software system. So far in 2023, we have received and addressed 271 food and nuisance complaints. The other type of complaint that we get is a foodborne illness complaint. These complaints are filed when a person is actually feeling ill and believes they were ill because of a meal they ate at a food establishment. Although we get these complaints in the typical fashion of phone calls, emails, and walk-ins, all complaints of foodborne illnesses are directed to be filled out on a questionnaire on our website. This links them to the state of Nebraska Red Cap system, which allows the state to track foodborne illnesses complaints across jurisdictions. This allows state to identify trends more quickly instead of each jurisdiction having to identify the trend and then report it to the state. The Red Cap system was put into place in February of 2023, and since that time we have received 90 foodborne illness complaints, none which have led to a confirmed outbreak. I would like to note, however, that immediately prior to changing to the Red Cap system, that a very similar system that was ran by Douglas County Epidemiology Section was successful in identifying a salmonella outbreak in Douglas County associated with sprouts. And that brings me to my next few slides, which are investigations that we performed in 2023. So let's start with that previously mentioned salmonella outbreak in sprouts that technically started in December of 2022, but wrapped up in January of 2023. There were 22 people ill from sprouts produced by a manufacturer within Douglas County. This facility was not regulated by Douglas County Health Department as it was a manufacturer. It was a multi-agency collaboration between the Douglas County Food Safety and Compliance and Epidemiology sections, the State of Nebraska's Department of Agriculture, the Department of Health and Human Services, the Nebraska Public Health Lab, and the FDA. The food safety and compliance team was dispatched to 2 suspected food establishments that were serving the sprouts, where we identified the product and recommended that the establishment stop sale of the product, which they happily did. And we also requested that the establishment hold the product for the NDA to pick up the product before for testing at the Nebraska Public Health Laboratory. Douglas County was not involved in the investigation at the manufacturer, as it was handled by the NDA and the FDA. Luckily, no deaths resulted from this outbreak. In November, the FDA detected elevated lead levels in children's fruit puree. This led to the nationwide recall of the product. After the recall, a national retail chain was identified as not following the recall guidelines, and the FDA requested a recall audit on the chain. That retail chain has 12 locations within Douglas County. So food safety and compliance inspectors and a lead risk assessor conducted on-site audits where they found that 3 of the 12 locations still had the product on the shelves available for purchase. Per recommendation from the FDA, we ordered the destruction of the product and observed the product being discarded by the establishments. This is a pretty widespread issue. As of December 15th, there were 67 confirmed cases, 122 probable cases, and 16 suspected cases from 33 states. Douglas County has 1 probable case. The last investigation that we performed in 2023 also started in November. It was a salmonella outbreak associated with cantaloupes. As of December 15th, there were 302 confirmed cases, 129 hospitalizations, and 4 deaths from 42 states. There are 4 confirmed cases in Nebraska, but 0 confirmed in Douglas County. There was 1 complaint of salmonella-like symptoms from a family in Douglas County that had consumed cantaloupe. The Nebraska Public Health Laboratory asked Douglas County Food Safety and Compliance to collect the remaining cantaloupe for testing. However, those tests did come back negative for salmonella. So what do we do that was new in 2023? As previously mentioned, we were able to hire a grant-funded EHS1. We originally considered hiring this position as a community educator, but decided that the position needed the educational background and qualifications to sit for the REHS-RS exam. That's the Registered Environmental Health Specialist, Registered Sanitarian exam. So we ultimately decided that it was best to hire the position as an EHS1. This position was hired with funds from the CDC Infrastructure Grant and for workforce capacity. This position was hired with 2 points of emphasis in mind. First, food safety education in a non-enforcement role. And why is that important? That's important because programs across the nation have found that when food establishment operators receive education from an inspector, operators don't comprehend the information as well because of the stressful nature of the inspection. Furthermore, the operator may not be 100% truthful with the inspector for fear of receiving a violation, leading the inspector to trying to fix a problem that doesn't exist because the operator gave the wrong details. As opposed to having a non-enforcement educator in the facility where operators can explain what their processes are without fear of receiving a violation, leading us to be able to get to the core of the issues with food safety and help them correct them. This also allows the operator to learn in a lower stress environment. With this position, we intend to create a voluntary program to do on-site education for establishments that have been identified to have food safety issues and help establish active managerial control. Active managerial control is when a person in charge is actively observing and checking for food safety risk as the processes are happening so that the risk can be mitigated before they happen or immediately after they happen to create a proactive food safety environment, as opposed to the reactive process of health inspectors coming into an establishment and telling an operator that what they've been doing isn't safe and then correcting it. This program will emulate an already established program that the Lincoln Lancaster Health Department is doing. That's called the Infuse program. And our friends at Lincoln Lancaster have been kind enough to offer for us to shadow them when we're ready to create this program. So we'll be able to go down there and see what they're doing. A second emphasis of this position is health equity. The year of 2022 marked the first year that the Food Safety and Compliance section had a Spanish-speaking inspector. However, that inspector we hired is responsible for her own territory and is not readily available to accompany the other inspectors to Spanish-speaking establishments. The grant-funded EHS1 position does not have an assigned territory, so therefore it'll allow the position time to be with other inspectors and focus on supplemental training in Spanish-speaking establishments. This position will also create and provide food safety material in Spanish, such as informational handouts, educational videos, and perform live food safety trainings, both in English and Spanish. So in 2024, we will be transitioning our inspection software from DHD to Inspectigo. Currently, our inspection software provides digital inspections of brick and mortar establishments, manages and tracks food and nuisance complaints, manages inspector schedules, and manages active brick and mortar permits. Inspectigo will do all those things plus much more. It'll allow us to do digital inspections and permit tracking on temporary events, farmers markets, and daycares. Most importantly, it'll revolutionize the way the section operates by allowing the online applications for new food permits of all types. It'll track the progress of those applications and send the applicant notifications on each step of its review process. And once that application is approved and the permit has been granted, it automatically sends the Nebraska Department of Agriculture and the Douglas County Business Office updates on the new permit and any subsequent changes. This may seem minor, but currently we're doing a triplication of efforts for every permit. Whenever a permit gets created or changed, the paperwork must be submitted to our secretary, who changes it in our software. Then she has to copy it and send it through the mail to the NDA, and lastly forward the paperwork to our business office. The paperwork then must come back down from the business office and be filed with the new system. Once the change is made in our software, all parties are automatically sent an update, no paperwork needed. The software also automatically updates the food establishment rating website that I showed you earlier, which is also a huge deal. Currently, our inspectors must print off their inspection reports so the secretary can edit a massive and complicated Excel spreadsheet that we've been manipulating over the past 15 years. The spreadsheet then must be sent to the county GIS team, who must manually update the website. Also, with the current software, the inspectors must carry around cumbersome and expensive printers to print off the inspection reports to leave with the establishment. The Inspectigo system will be able to automatically email the report to the establishment operator. As you can see, this software will significantly reduce duplication and triplication of efforts and essentially pay for itself with the time it's saving in person hours and reducing the need for equipment such as printers. The software will also allow for better stakeholder communication by hosting a portal for food establishment operators to log into for resource material and DCHD updates. And it'll also host an email list for DCHD to send out correspondence and reminders. For example, like our invoices go out in November, we could send an email out in October that just reminds establishment operators to be looking out for those invoices. Sometimes, unfortunately, those go right into the trash. Also new in 2024 is our mobile unit reciprocity. Legislative Bill 562 revised Nebraska's statute to allow for local jurisdictions to be reciprocal to each other's mobile unit permits. Jurisdictions were given the choice if they wanted to participate, and all three local jurisdictions did opt in. So an interlocal agreement was created and submitted to the state on November 14th, 2 weeks prior to the deadline. So what does that mean? It means that mobile units with an active Lincoln Lancaster or Central District mobile permit will be allowed to operate within Douglas County without obtaining a Douglas County Health Department permit, and vice versa. This is intended to go into effect January 1st, 2024, and the agreement's valid for 3 years, at which point it'll be reviewed and updated if needed. There are a couple things that we hope to happen in 2024. Hopefully, Nebraska will adopt the 2022 FDA Food Code. As you saw at the beginning of the presentation, we are currently on the 2017 Food Code. Typically, the FDA releases a new food code every 4 years. However, COVID delayed that for 1 year. And then Nebraska usually adopts that FDA Food Code 2 years after its release. There is one change that is particularly of interest that I'd like to mention. If the state does adopt the FDA Food Code, and if it decides to update this specific code, local jurisdictions will have the option to allow animals on patios of food establishments without a variance. I'm not sure if this board is familiar with our current variance, but honestly, it's quite difficult for establishments to comply with, and that has resulted in only 3 establishments in Douglas County that have successfully qualified for the variance. Also projected for 2024 is a completely revised Chapter 11 of the Omaha Municipal Code. Chapter 11 covers the rules and regulations for food establishments in the city of Omaha and is horribly outdated. The ordinance predates the MOU between the NDA and the DCHD, so much of the ordinance does not reflect the operations and practices used for the food establishment regulation within Douglas County. The Douglas County Health Department has been attempting to get this ordinance changed for a better part of the last 10 years, and we're closer than ever to making it a reality. The ordinance update is currently with the city attorney, where they are putting it into a legal format. The ordinance update will need to be approved by the city council, where it will go through the standard public readings, but before it gets to that point, it will be presented to this board and the Omaha Restaurant Association for review and feedback. Some of the highlights of the ordinance change include it'll clarify the health director's authority for food establishment closures and outlines establishments' rights to objections and requests for hearings. It updates the code to reflect current permitting practices. It updates the code pertaining to mobile unit requirements. It establishes authority pertaining to cottage food vendors and child care centers. It will require food handler certificates for all food handlers in Douglas County. It requires food protection manager certificates for any employee identified as a person in charge, and it prohibits bare hand contact. Those last 3, Lincoln Lancaster has been enforcing for multiple years now, and it's gone successfully there, so we hope to do the same. I'd like to talk about some of the program challenges that we've been experiencing. The first of which is illegal vendors. There are a few different types of illegal vendors that we deal with. First, you have your vendors that are selling time and temperature control for safety foods out of their home, booth, or mobile unit without a permit. These vendors typically are aware that they're breaking the law, so they operate at times when they know we are not working, such as nights and weekends. You can see an example of one of these illegal vendors here. It's this bottom right picture. This vendor was selling burgers without a permit. You can see that the vendor has even got some cutting boards to cut up the toppings for the burgers here. This poses a risk because there are no hand washing facilities, no warewashing facilities, and no proper refrigeration. The next type of illegal vendor has a permit, but they're doing activities not allowed under that permit that they have. For example, you can see this vendor in the top right. They have a permit to be selling prepackaged ice cream and cotton candy, but this vendor is also cutting up mangoes and has some shaved ice that they're adding flavoring to. This poses a similar risk because there's no hand washing available. These vendors are usually also know they're not supposed to be doing this. Both of these vendors did receive a citation from the police this summer. We also see a lot of illegal food sales happening on social media. Most of these vendors are selling TCS foods out of their homes. Some of them know they're doing something illegally, but some of them really don't have a clue. Lastly, we have cottage food vendors that are unknowingly selling foods that aren't allowed under the law. Cottage food allows people to sell non-TCS foods such as cookie and breads from their home as long as it is direct to the consumer. But some people are selling products such as cheesecakes and desserts with cream frostings that must be refrigerated. So we just spend a large amount of time informing these vendors that what they're doing is technically illegal. So what are some of the possible solutions for these challenges? First, if we had an increased media and social media presence to inform the public of what is and isn't allowed. Also, funding to pay employees overtime or funding to hire an employee to work nights and weekends to address these illegal vendors would be helpful. Our next program challenge is the rapid influx of temporary events and farmers markets. The number of these events has nearly doubled over the last 10 years, and the size of these events have grown exponentially. Our largest event has been between 60 and 70 food vendors. The issue that these events The issue with these events is that they normally happen outside of normal working hours, meaning that comp time and overtime is needed to pay the employees. This time's not budgeted in our payroll, so other budget items must be hit to cover the funds. Some possible solutions are the same as before, either finding the funds to pay employees overtime so it doesn't affect other budget items, or finding the funds to hire an employee to work night and weekends when these events take place. Our last program challenge I'd like to talk about today is the food safety knowledge of food establishment employees. Food establishments historically have had high turnover rates. It's just kind of the nature of the industry. This problem was exacerbated by COVID. The problem is that inspectors spend a significant time during their inspection during their inspections doing food safety education. But when we return 6 months later for the next inspection, they find that we have to do it all over again because the staff has completely been turned over. A solution to this is requiring all employees that work in the food establishment within Douglas County to take training and get food safety certification. Also, any person in charge must take and pass the food manager's certification. This helps ensure that food safety is being considered at all times, not just when the health inspector is there. Also, when we hired the EHS1 community educator, that should also help tremendously in this area. I just want to touch on, every job position out there at the end of it says among other duties. I want to touch on some of those things that we did this year. The food safety and compliance staff participated in the oral vaccination distribution for the raccoon rabies response effort. You can see here, this photo is sanitation and sanitary engineer also helped out with that. And also food safety and compliance employees helped with the TB testing clinics that were held this fall. I'd like to give a special thanks to Dr. Hughes for her support through all the changes that have been made and we're trying to make. I'd like to thank the food safety and compliance team. I've challenged this team significantly and they've responded admirably. Not only have I challenged them, but they've also challenged themselves and me to continue to improve the section to provide better services to the community and to the establishment operators. I am truly honored that they allow me to lead them. I'd like to thank Dan Ludwig. Dan was the one that stepped up as interim supervisor last May, and he got the ball rolling on many of the things that we were able to successfully implement in 2023. I'd like to thank Pat Lanfear. Pat is a retired health inspector that comes back part-time and bails us out whenever we get too far behind. His help is greatly appreciated. And finally, I'd like to thank Connie Blackburn for making my presentation look professional. And with that, I'll take questions.
So, Adam, I was excited to see your presentation on the list. I don't get an opportunity on the board to get food service topics coming through. So, just a couple questions and comments. Probably the first one, so 6 new inspectors this last year that you hired. So that brings up, you said there's a total of 10, including the supervisor?
There is 10 inspectors, and we did hire one more environmental health specialist who typically is in an inspector role, but that will be in more of a community educator role. So 10 inspectors with territories doing inspections full time.
Okay. So then with that, and 5,523 inspections in a year, and roughly 260 work days, getting close to, over 2 inspections every single day that you guys have to go through, plus all the other things you were saying.
Correct.
I mean, do you feel like that is a realistic workload with the other things on top of that, or do you feel like we're budgeted correctly for?
Yeah, well, if you go by standard 8 of the voluntary national food retail standards that the FDA puts out, we should actually have 18 full-time equivalent inspectors for our workload, not including supervisor or division chief. So according to the FDA models, we're 8 inspectors shy.
Yeah. Well, I just wanted to recognize how hard all you guys are working.
Thank you. They do work very hard.
Although I know you made a big point talking about the new Inspect-to-Go software, but I've seen that firsthand on how much repetition or how long all the inspections and paperwork take to be able to get through that. I think that will be huge, and hopefully that will take a load off of everybody that's stretched thin in the field. So
yeah, we really hope so. It should make our program so much more efficient.
Yeah. So with the new inspectors this last year, and then we're talking about the new food code coming out potentially in 2024, what is the process for the standardization and training of all the inspectors to get everybody kind of on the same page? So, I mean, frankly, I mean, it's over the years, and I don't think this is necessarily a bashing at all, but coming from the industry, inspector to inspector, they all have their hot buttons that they look for when they go in. And so when you have a new inspector, when they rotate a territory as an establishment, we'll see like, oh, you know, this new inspector really looked at these items, whereas the one I had for a few years never said a word about it. And not saying that it's like, we're not talking like big problems like, oh, the temperature, you know, was bad or something. I mean, but some things. And so I think there was some conversation previously about like the process of the standardization. Can you tell me a little bit about how that works?
Sure. Heather, or Tony, would we like to take the presentation down so the cameras are working? Yeah, so the voluntary national food standards actually have standard 2 is standardization of employees. So we follow that model, and we're actually even a little more strict than that model. So they come in with their standardized training, without going into too much detail. But after they're trained, within a year, they're supposed to go through what they call standardization, is kind of what you're talking about. And Douglas County hasn't been able to meet that standard. It's one of the only standards that we haven't done self-assessment on and identified ourselves as meeting, because we haven't had the time or the staff to do that standardization, because standardization has to come down the line. First, it starts, FDA standardizes the state, and the state standardizes an employee at the local level, and then that employee will standardize, which at our level is the EHS 2s. That's part of their responsibility. And then those 2s would standardize all the 1s. But there's been some difficulty with getting standardized by the state, and then once we are standardized, it's been difficulty having the time and the staff to standardize the other inspectors. But inspection consistency is paramount of one of our concerns right now, and we are with this extra EHS 1 that we're able to hire, that inspector will be able to take some of the workload off of our 2s, and therefore our 2s will be able to standardize our 1s. So hopefully we're much more consistent in our inspections moving forward.
Okay. Do you know how, now I think you brought up like the turnover in the industry and the challenge of, you know, when you go back for your 6-month inspections about having to kind of redo it. And I think that probably, I don't see our industry ever changing. You know, I mean, that's just kind of the nature of what hospitality industry is. But as far as like the number of violations or the level of inspection scores, do you see any kind of trend happening over the last year or two, improving or going down?
Yeah, we certainly saw the inspections, the performance of the establishments decline since COVID.
Mm-hmm.
And that was directly related to just low staffing and staff turnover.
Mm-hmm.
Yeah.
Okay.
And I kind of like to tell this story. I spent 9 years as an inspector, and before COVID, I never had to explain to any establishment what a health inspection was or who a health inspector was. But things were getting so difficult since COVID that I made that part of my initial spiel when I walked in, is who I even was, because people are so unfamiliar with food safety and health inspectors that I had to do that, which was concerning.
Well, I guess the last thing I wanted to throw out there, you know, I think your department does a nice job with developing the culture of teamwork with the establishments out there. You know, could very easily be like, you know, oh, here comes the food police, you know, coming in to crack down on things. But I think across the board, all the inspectors that we've worked with over the years, you know, are doing there as educators primarily. And then, of course, obviously keeping the public safe, but educating and trying to get the establishments up to speed on how to do things the right way. And then I think been a really good effort over the last several years to be involved with the industry, like with the Omaha Restaurant Association, or getting communication out more with the establishments. And I think we see a little bit of improvement in getting invoices paid for permits, I mean, I think is trending, maybe not perfect certainly, but seems to be a little bit better than what it had been years ago. And so hopefully with that culture that, and some more of the education and changes with the Chapter 11 municipal code that we kind of turn that trend around.
I hope so too.
I appreciated John's line of questioning there. I get asked those questions a lot too when I'm out and about. And I would just double down on the observation about Chapter 11, if you're working through that, to make sure you are engaging the Restaurant Association and others up front, because it is a cooperative effort. We want to make sure that when that is being formed and potentially coming to the City Council, that we have all interested parties aware of it and on board with working to make our restaurants safe, but also operational and recognizing they have challenges too when they're trying to help address these issues.
Yeah, absolutely. Stakeholder communications is number one when trying to do something like an ordinance change, right? Because if you push it through without feedback, it doesn't usually turn out that well. So that's at the top of the list when we're doing this process.
Okay, thanks.
Adam, given what you indicated about the need for more staff in your department, do you have an idea of how that is affecting our FAB accreditation? Because if the health department is understaffed and not in danger of not being able to meet the public health food safety, then I'd like to hear from you what this board should be addressing so that we are better situated to meet, the standards by the Environmental Health Division as well as the Public Health Accreditation.
Yeah, I'm not, thanks for the question. I'm not real familiar with accreditation and how that affects, our getting accredited as far as our staffing. I will say, to me, it's a lot of people have a hard time meeting the FDA standard for their full-time equivalents, but to get closer to that it would look like somehow finding additional sources of revenue or obtaining more county dollars to cover those employees.
Thank you for the presentation, Adam. I definitely learned a lot. One of the things that was a little bit striking to me was the night and weekend inspection issue. And what are other communities around the country doing to address this? And is this an opportunity maybe the community educator could have a part in so it doesn't seem so punitive necessarily? Or do other places maybe do a rotating schedule so that those are being addressed? It seems like there's more and more on the street.
I think for the most part they have dedicated inspectors that work nights and weekends. Is generally how that gets addressed.
Is that referring to, because I guess I had one question, is that referring to the TTCs? Is Dr. Jones' question? Because I had a question in respects to the average person on the street. They walk up to, left two examples, and I'm sure they don't know the rules. I'm just curious, how do you get that? Do one of you all happen to be walking through and somebody sees this?
Oh, how we see the illegal vendors?
Yeah, and I'm just wondering, was that?
It'll be by happenstance a lot of the time, and actually a lot of the times permitted establishments that are doing things correctly will make complaints because they see people doing things incorrectly and skirting the rules and not having to pay the appropriate permit costs.
Can you explain Dr. Jones' question again? I may have missed that. I heard it, but I may have missed where she was coming from in the presentation. Can you explain the context of what she's saying there?
I think you were asking how other jurisdictions are addressing the nights, not having anybody on duty on nights and weekends. And
if that's not being done currently and it's just people know that you're not, working at night and weekends, then that's an opportunity that they can.
Right.
And it seems like a big area that's lost.
I believe other jurisdictions address that by having a dedicated employee working nights and weekends. And
how does that work? Because I thought it's like something you discover and you just make aware of the next day or the next deal. How do other people do that where there's a person night and weekend?
I guess I'm sorry, I'm not following the question.
How is that addressed? Because I'm assuming.
How is it addressed by us right now?
Well, yeah, because I'm assuming to Dr. Jones' question, there's a violation or something, you would get it the next day or on that Monday. I mean, how?
We have
how
to
should
pay,
it be?
the inspectors have to be paid either compensatory time or overtime to go
Oh,
out.
for having their, if they're working during that period. That's
Yeah,
what I'm talking about. Okay,
yeah.
okay, all right, I got it. Let me ask you, I'm just curious, explain that last part that you were saying in respects to John's question about having to identify yourself after COVID.
Yeah, I was just kind of saying that before COVID, staff wasn't turning over quite as much.
Okay.
And you'd have employees in food establishments that had been around long enough that they knew what a health inspector was and what they were there doing. And during COVID and after COVID, there was so much turnover that sometimes I'd walk into an establishment and they would have no clue what a health inspector was. So I had to start kind of explaining and made it a routine to explain who I was when I walked into a restaurant, because it used to be people say, hey, I'm the health inspector, and they knew that you were just coming back into the kitchen and what you were doing. But these days, if you walk in and say I'm the health inspector and don't completely explain why you're there and what you're doing, people kind of get spooked.
You all get a badge or something like that? Like
Yeah, we have a badge. Yep, we have a badge.
Okay. No, okay, not like a law enforcement.
Not Larry the Cable Guy badge. Nope.
Okay. So let me ask you this. I'm just curious, when you said the digital inspection, you just meant you basically got everything kind of digitalized. Because when you said a digital inspection of brick and mortar, that kind of caught me. But I guess in essence, you're pretty much just digitalizing the process.
Yeah, so when I started 10 years ago, we were still just doing carbon copy paper forms, handwritten. Yeah. And then shortly after that, the digital health department, the inspection system we're on now, allows us to do those on the tablets that we have with us. So we're able to do it on a computer, essentially, okay. And then that generates a report.
So that confirms, yeah, you digitalize the process. Okay. Mm. I'm just curious, have you all seen an increase of mobile units coming in since that reciprocal law to some degree?
It hasn't gone into effect yet, and we don't expect a ton, because typically we don't get a lot of mobile units from Lincoln, okay. Or Grand Island. I'm honestly only expecting a handful, but I suppose once they understand that they don't have to pay any additional fees, maybe it'll increase.
Okay. I think that's all we got.
All right, thank you.
That's a very good presentation. That
thank you.
Opened me up to a little more behind the scenes. I appreciate it. You're doing a TB response?
Okay. Yep, I'm back. Hey, and I just want to take a minute to congratulate Adam and his team on all the work they've been doing. I've been with the department for almost 21 years, and I don't ever remember a time that we've been caught up to the level that we are. And so I think his presentation today shows you just how dedicated that team is to their jobs. And the health director and I and Adam have started having some conversations around all of environmental health, actually. We do a lot of services for free. And we've started some discussions about maybe starting to charge for some of those so that we can have the appropriate level of staffing to do the job that we need to do. So just wanted to add that. So congratulations, Adam. I think it's fantastic. The health director asked me today to give you an overview of the TB response last month that we did, and kind of the heavy lift so that you have an idea of what the health department kind of went through. While we go through this, keep in mind we were wrapping up the Eastern raccoon rabies response, which was also a giant lift. And I want to take a minute to brag about our department. With the rabies response, the CDC and the USDA said it was one of the most organized responses they had ever been a part of. So I think that was fantastic for us in our community. But the TB response started on November 7th. We were notified the previous week, late in the week, that we had a new active case of pulmonary tuberculosis. Through case investigation and contact tracing, it came to our attention on the 7th that there was a child care center at a West Omaha YMCA that was involved in potential exposures. What made this daycare unique is that it was a drop-in daycare where parents would bring their children, drop them off while they worked out, and then they would leave. So when I was first notified that we had a daycare involved, I was thinking we might have 30 to 40 kids in a classroom, right? And after doing some really intense cross-referencing with the daycare attendance records that the YMCA had, they actually had a digital check-in, so we were able to pull those records and cross-reference with the time that the case was there. We found about 556 children were exposed and 37 adult staff members. The ages of the children range from 5 months to 12 years, and I think that's really important to keep in mind because children that are 4 years of age and under can develop really rapid onset of tuberculosis, and the infection likes to go to the brain. So it was really important that we put together a response very quickly so that we could get those kiddos in, tested, evaluated, chest x-rays, and put on what we call window prophylaxis, which is an antibiotic that they take to prevent them from developing disease until we can get them back in and test them again to make sure that they haven't been infected. So what is TB? It's a bacterial infection that can really occur anywhere in the body. But when we think of TB, we often think of the lungs and pulmonary disease, right? But actually half of our cases, or a little less than half of our cases in Douglas County are typically extrapulmonary, meaning that they're outside of the lungs. We've seen it in the eyes, spine, disseminated throughout the body, kidneys, etc. If you're unfamiliar with tuberculosis, you can have TB but not be infectious and not actually have what I would say active disease process occurring. That would be latent infection. It's almost like your body's walled it off and it's kind of keeping it there. So we do treat folks for what we call latent TB so that they don't develop active disease later or active tuberculosis. TB is fatal if it's not treated. So where does public health and TB kind of intersect? Well, we do surveillance, obviously, and case management, including directly observed therapies. So we have 2 nurses on staff. Both are absolute rock stars and did a fantastic job in this response. But they will go out, they'll interview cases just like we did with COVID. I know that we use that as an example a lot, so I'm gonna have to change that soon. But they'll do case investigation and then they'll do contact tracing. So we'll identify folks that could have been exposed and then we'll test them. If they're positive, then we'll get them in for a medical evaluation and put them on treatment. For the case themselves, we do what we call directly observed therapy. That's where we actually go to the patient's house or place of work, or we do it over video. And we monitor them taking their medication every single day, Monday through Friday, excluding the weekend. And that's really best practice for tuberculosis control. It's assuring adherence to the medication because we don't have a lot of drugs to treat TB. It's pretty limited. And it's also protecting the community by assuring that they continue with their medication. So I'm just going to give you a little bit of timeline of how quickly this happened. So we found out on the 7th, kind of middle of the day, and on the 8th I had asked our ERCs to pull together what we call our incident management team, which really consists of our managers that would be involved in this response and any of our subject matter experts in the health department. At the same time, we knew that this would be a large, multifaceted response, so we stood up Unified Command with YMCA, Children's, Nebraska Public Health Lab, Regional Pathology, the state of Nebraska, etc. Between those 2 groups, we came up with a lot of objectives really quickly. We knew that we had to do a CDC SME consultation to see how do we define an exposure? Does it mean everybody who was in that room? Is there an amount of time, etc.? And what we came up with is if we had an individual in that room for 20 minutes or more, that was an exposure. And that's how we came up with that 550 plus individuals. We then triaged contacts based on their date of last exposure and age. So again, those that were 4 years of age and younger and had an exposure within the last 10 weeks, those were kind of our top priority. We knew that we had to notify parents very quickly and staff. So risk communication, crisis communication was huge in this response. Part of the reason I'm very excited to hire a new supervisor of communications I learned very quickly that I can't be incident command and write those communications at the same time. It was a little overwhelming. We identified testing opportunities with a mass clinic that the health department was going to set up, which is a massive and intense undertaking. And we were able to work with Children's Nebraska to test those kiddos that were 4 years of age and younger, because they would need to be seen under a physician's care to receive that window prophylaxis. We worked with the Nebraska Public Health Lab to ramp up testing capacity, because they don't have this number of what we call quantiferons or blood tests. They're not used to running that many. They also had a scheduling system. The finances of this response was huge. We had a lot of questions about who's going to pay for it, how are we going to pay for it. We don't have phlebotomists, so we had to bring in phlebotomists for our mass clinic and things. So it worked really well. NPHL, or Nebraska Public Health Lab, they have a scheduling laboratory system that was also able to collect insurance information. So this was actually the first time that the health department collected health insurance information and was able to bill direct for tests. We had to write a physician advisory, or a HAN, a health alert. We drafted press materials, and then we declared a public health emergency, which I think you are all familiar with. So all of this happened in one day, sitting around in the conference room with our incident management team in Unified Command. And I just had to say that I was super proud sitting there, because I'm not sure if a few years ago we would have had quite the partnership that we had around the table and the expedited response that we had. So I couldn't have been happier.
Can I ask you one question in that respect?
Sure.
So, in a case like this, how did you first find out? So you're at your job on
on
a Wednesday, and found out, and all this happened within 24 hours. But how did you first find out and know that this was something you had to focus on?
So there's Title 173 of the Nebraska State Legislative Code that has an entire list of infectious or communicable diseases that are reportable by law, tuberculosis being one of those. So we're always notified when there's a case of active TB in our community, and that sparks a public health investigation. And so that's when the TB nurses would go out and start that process. So they would, again, do a case investigation, contact tracing, test folks in the house, make sure that there's not kids in the house that would need to be put on window prophylaxis and things like that. So through that interview process, we found out that this individual had ties to this particular YMCA drop-in daycare. Okay. And then that's what sparked the big response.
All right. Mm-hmm. So you were first notified by a physician or by a...
Typically, it's either by a physician, or we receive laboratory reports electronically. They come into our system. So let's say you test positive for E. coli. Once the laboratory puts your test result into their system, it automatically comes over to public health, and we're notified within that same day.
Okay. Yep. Got it. Thank you.
So like I had mentioned, communications was huge, and we really had to get this right. You know, in risk communication, you want to be accurate, and you don't want to lose the trust of your community. So this letter was the letter that was sent to each parent individually. You can see the child's name in red and their last date of exposure. So we, again, addressed every single parent of every single child that was part of the exposure. And that last date of exposure was used to determine what type of test they needed and where to go. Okay. We were able to utilize, again, that scheduling system. So we have a QR code there. You can see that parents could scan and schedule a time with us. And then children set up a call center that we're scheduling patients there. We also had to send a letter to all the parents who had children who were not exposed, because we knew we would have a lot of questions about that. So that was an additional communication that we sent. Dr. Matt Donahue, our state epidemiologist, he came down and helped put together our health alert, again, to local pediatricians and physicians, notifying them that we had a case of pulmonary disease, tuberculosis, in a child care center, giving recommendations what they could do if parents showed up in their clinic and chose not to use one of ours, either through Children's Nebraska or our mass clinic. And again, I think you were all aware of the declaration of the public health emergency. I just want to stress that one of the reasons that we did this, it was more administrative in a sense because we were being questioned by some of our community partners that were helping in the response and also parents who had children of who was going to pay for this. And right now the health department has no set aside funds for public health emergencies. And if you look at kind of the tempo at which these emergencies are occurring, they used to be one every couple years, then we went into one every year. Now we're having multiple of these each year. So we just went from rabies to tuberculosis, and now we're looking at a potential mpox response again, right? So a lot of the funds that we use to cover this is through attrition and other means of savings throughout the year. But something to kind of keep in the back of our mind is this is maybe not the most sustainable approach. So then on Thursday, November 9th, we continued with all those priorities that I've already talked about, but it was more logistics. You know, we need people, we need supplies, we need to move them. How are we doing all of this? We worked with the YMCA to send those notifications to parents. Those went out earlier in the day on Thursday. And that evening, myself, Dr. Hughes, and then Dr. Kari Neiman, our medical consultant, were all on site at the YMCA. We held an informational meeting and then a Q&A for parents to ask us questions. And immediately following that, we did a press conference. We wanted to make sure that we answered parents' questions before we went to the press. On Friday, November 10th, we opened our information line so you can see how resource intense this response was. So we had to pull folks from across the department to staff that information line. And at the same time, we attempted phone calls to families that had not yet registered with Children's Hospital or with our clinic that was going to be held the next week. The Children's Clinic was actually held that following day on the 11th and the 12th over the weekend. So we were moving very quickly with our infectious disease partners over there. That Friday, Dr. Hughes and I, we ended up doing interviews on national platforms with NBC and the Washington Post. It actually had quite a bit of attention nationally. So then on Saturday and Sunday, like I said, Children's Nebraska, they did a fantastic job of seeing children there. I think they ended up seeing 273 kids over that weekend. They had volunteers from all over the hospital, pediatricians from other areas of the hospital, not just infectious disease volunteer. I believe they worked 4-hour increments both of those days. They performed the TSTs, or the skin test you are probably familiar with, or a blood test, which is known as the quantiferon. And then they did chest x-rays, and if the kids were 4 years of age or younger, they would prescribe them window prophylaxis, which is, again, that antibiotic to keep them from developing active disease, much of which had to be compounded, so they had to bring in additional pharmacy staff as well to turn that into a liquid suspension. And then they provided follow-up instructions. On Wednesday, November 15th through Friday, November 17th, we set up our mass clinic at the YMCA in one of the gymnasiums there that you can see. This went super well. I think we had one specimen perhaps that we needed to redraw, but otherwise it went fantastic. We had Nebraska Regional Pathology assist us with that, and actually they sent 7 phlebotomists over to help us do the blood draws. We started receiving test results within 24 hours, and then we continued to do outreach to those that had not yet registered. We really wanted to do our due diligence to make sure folks got the information. So the original letter went out via email, and then we made at least 2 phone call attempts, and just this past week, I believe we sent another letter to folks about needing to see their physician to be tested. We also drafted a what's next communication, which you can see here, and it was basically explaining to folks whether their child needed 1 test or 2 tests depending on the date of last exposure, and where that could be done, and when we would be setting up our next mass clinic after the first of the year. From an epidemiology perspective and data management, we had 0 room for error when we were collecting all of these test results. So we ended up with over, I think close to or just over 600 test results that came in. All of those had to be entered into our surveillance systems. And then we had to actually provide those test results back to families. So we drafted a letter and then printing, stuffing, all of that sort of thing. But again, we wanted to make sure that we didn't mix up a name with the test result, et cetera, right? So a lot of work went into multiple different lists that we had, a lot of data analysis, data management. I also chose to take this as an opportunity to do a consultation with our Public Health Ethics Committee. I wanted kind of their opinion on when have we done our due diligence in trying to notify families? How many times should we try to attempt notification before we say we've done all that we can do? This is a test result letter. Again, as you can see, communication was a huge part of this response. So public health significance, I'm not going to go into this really much because of time, but obviously disease control, preventing future cases, preventing outbreaks, because this really did have the potential to cause mass illness. And then lastly, I just want to focus on the fact that collaboration, coordination with our partners, I can't stress enough, continuing to build our partnerships, professional partnerships with the community, whether that's our healthcare providers, laboratories, et cetera, other health departments, because when a response like this happens, if you know who to pick the phone up and call, things happen much faster. Some issues, I've already talked about some of the financial resources related to emergency response, and that we don't have a fund set aside for these. We had multiple public health responses occurring at the same time. Remember, we're still doing the rabies response, and we're still doing our normal work. We have very limited funding for tuberculosis. I think the county receives $20,000 a year, and we have anywhere between 15 and 20 cases on average, and those are all very resource intense, requiring 2 nurses and an epidemiologist full-time. The risk communication, I think, was a little bit of a challenge and barrier, because no matter how hard you try, I think there's always room there for improvement. But at some point, you just have to send that information out, right? But looking at how do we improve that process. So the results, again, we had identified over 643 when it was all said and done. If you remember, we had just over 550 originally. We ended up testing 504 individuals. We had 139 that we haven't been able to identify whether or not they've been tested. And again, that's through multiple attempts to get a hold of them, and also doing kind of chart reviews to see if we could identify whether or not they had been into their doctor. The health department, we ended up testing 177 individuals at our mass clinic. In Children's Nebraska, tested the majority of 327. A lot of those were siblings that came with or younger children in the family, so children's physicians just went ahead and tested them while they were there instead of having them go to the public health clinic. We had 135 kids that were put on that window prophylaxis to keep them from developing illness while we wait for second round testing. So far, and I'm optimistic, we've had 0 positives, and all 504 have been negative. Lots of acknowledgments. Health department, like I said, DHHS, the CDC, Nebraska Children's Hospital, couldn't have done it without them. Children's Nebraska Infectious Disease Group, fantastic group of people. The Public Health Lab, Nebraska Regional Lab, the College of Public Health, they had students come in and volunteer at our clinic to help direct traffic. Central District Health Department, both their health director and their TB nurse came down and assisted with placing skin tests and drawing blood. The Westview YMCA, fantastic partner throughout the whole response. The Douglas County Attorney's Office, thank you, and our local media. And that's it. I'm happy to take questions, but before I do so, there are a few people in the room I just want to recognize, because you guys probably don't get to see faces very often. And the first is Caleb Kudos. He is our emergency preparedness coordinator. And I can't tell you, Caleb rocked this response. He was in charge of unified command, our objectives, keeping us all on track, identifying all of our materials for the clinic, loading the vans, getting it there, staffing it. He did a really fantastic job, so thanks for that. Chad Wetzel, I think some of you may have met before. He took my place. He's now the supervisor of communicable disease epidemiology. So again, it's his team that oversees all of the TB response day to day, the case investigation, all the data that came in, and all the notifications that went out to families regarding test results. So I want to say thanks to Chad and also to the whole health department who assisted. It really takes a village to make these successful. So thanks. Yeah.
I have a couple here. Well, first of all, great work. Thank you for doing it. I mean, it's quickly put, kind of hopefully to bed. But the second round of testing, usually about a month, right? Or no?
So second round test. So if an individual has been exposed within the last 10 weeks, typically what we'll do, we'll test right away. Mm-hmm. And that's kind of our baseline. And then we'll test again after that 10 weeks. So for our clinic, just for timing purposes, we decided to go the first week of January.
Okay.
Some of those kids, if they were exposed in the last 4 weeks, then they'd only have 6 weeks that they would need to do window prophylaxis, and then they could be tested again, right? And the reason we do that is that it could take that amount of time for your body to have an immune response to TB that we can then detect.
So are they sending? So you guys are sending out a second set of letters reminding parents to get in
Mm-hmm.
and get
Yep.
their second test?
Yep, we just sent information out, and when we sent the test results out, we had another QR code so that they could register for second round testing if they needed it.
Good.
Yep.
Okay. I'm just curious, what's that number looking like? That budget number cost-wise? What's the range?
Funny thing, even though we had a lot of talk around what this is going to cost, and some of our partners were wondering if we were going to kick in to make up the difference, I've not received any sort of bill from anybody yet. So not from the hospital, not from the phlebotomist, et cetera. So I really do think that in this particular case, you could say maybe we lucked out. That the majority of folks had health insurance. I think a few may have had some high deductibles, unfortunately, but again, I think that everybody was reimbursed.
Good. I just note, Justin noted the day that everything kind of happened, and there was a discussion, so he mentioned it, and there'll probably be a discussion about that during our conversations budget-wise, but I think most likely it is going to be a move to set up a specific emergency fund to be able to get tapped into regularly instead of going to this, so just so the board's aware of it. There's no other questions, Justin, appreciate it.
Yeah, thank you.
Great job. I happened to be out there that night, and it was an interesting process watching it go all the way through, and it looks like all the parents and everything were fine with that response. If anybody got any questions from those reports, and I know Leah's on, but Leah, I got one question. I think you may have said this before, but when you mentioned on page 2 of that report, the media campaign with Commando, I may have heard this before, but remind me what Commando is again, when you talk about the media campaign under STDs and STIs. She's there. I don't know if she's.
So we'll see if Leah jumps on here, but Commando is a LGBTQ social media platform, so they reach across all kind of dating apps, and we've had great success with that, advertising for Mpox vaccine, and now moving forward with STIs and syphilis.
Okay. All right. Yeah, that's all I have on that. Any other questions from anyone else?
I'm just going to see if we can get an update on Baby Blossoms. If she's not available right now, maybe our next meeting we could.
Leah? You mean Leah?
I'm here. I'm sorry.
No, I got the answer. It was about what describing Commando again. I got it.
Okay, good. Sorry.
But if anybody's there on Baby Blossoms, there's a question out here.
What's the question for Baby Blossoms?
I'm just wondering, I know there's been a lot of energy behind, infant health and maternal health, and I'm just wondering, Like, is there anything that the board can do to support or help the rebirth of Baby Blossoms? Or can you give us an update maybe at the next meeting about what's going on there?
Yeah, I can give you a real quick one now. So we had a Baby Blossoms meeting in November, and we're planning on continuing those with some other folks until we can get that position rehired and get someone on board. As for the public health nurse, if anybody has a public health nurse that would like to apply for our FEMR position, that would be fantastic. That's what I will ask of the board. Please help me find a PHN for FEMR.
Okay. All righty. With that, I just note, it looks like there wasn't anything that warrants a, the administrative meeting, which is scheduled for the first of the month. So likely that won't happen. Let me note if, Justin, if you can make sure those presentations get sent out to the board in case people want to look at them anymore. Note for the board, if anybody's interested in officers, please let me know. If not, what I plan to in the agenda piece next week is just to put the current officers on for a continued term. If there's a current officer that doesn't want to continue, let me know. If not, that will be put on the board to just confirm next month. Also, I'll just put everybody on notice. It's going to be an interesting, when we come back in January, you may be close to the 10-day period in the legislative session. I just marked that it's going to be interesting just because of the bringing up the circumstance of the 8 employee difference in food inspection, the other issue with the fund, and it's not just here, but everywhere over the county. There's going to be a couple of revenue sources that are going to be under duress and looking at. So it's going to be a interesting year in regards to any entity that relies solely on property taxes for money, because it's going to be an interesting point to see what they do with revenue sources they change. And the one big one that the county uses in respects to cover any gaps, the inheritance tax could be under really serious assault. That brings us about 14 to 13,000 a year, and we use that to balance the budget in a lot of departments in years that it's there. So I just put that on note for the public and for record. With that, there's nothing that I have, no need for executive session. I'd ask for a motion to adjourn and wish everybody Merry Christmas, Happy New Year. Is there a motion to adjourn?
Motion to adjourn.
Motion by Festerson, is there a second? Second by Dr. Jones. Roll call.
Wade? Yes. McNally? Yes. Festerson?
Yes.
Jones? Yes. Rogers?
Yes.
Espinoza? Wilkin?
Thank you all. See you next month. Huh?